Hello dear students. In this session, we will discuss orthopedics question which were asked in the recently concluded FMG exam, which was held on 26th of July. So for the ease of understanding the topics which are really important from exam point of view, I have categorized the chapters or the segments from which the questions were asked. There was one question from complication of fractures. Then the lower limb trauma, it was the most dominant segment, and there were three questions from this chapter. Then nerve injuries, there were two questions, and actually these were integrated with trauma, so it was a kind of integrated uh, concept. Then from pediatric trauma, there was only one question, and there was one question from infection. And surprisingly, there was no question from bony tumors. So that is very rare that we don't have a question from bony tumor chapter. Anyway, but yes, if you look at the gross picture, the important chapters, they gave us the questions in this exam. So moving forward to the questions and taking the first question, which was from the complication of fracture. And here, an elderly woman was involved in road traffic accident, and now she is having difficulty in breathing, and there is altered mental status, right? And when the x-ray was done, it was noted that there are multiple fractures. Now what can be the diagnosis here? So to get up to the diagnosis, we have to evaluate all the keywords. So the very first keyword is multiple fractures. Now, this is one of the important keyword. And after this, the lady was having respiratory problem. So there was respiratory problem, which was like uh, difficulty in breathing, what we call dyspnea. So there is difficulty in breathing. And there was neurological manifestation as well. Neurological manifestation as well, which was in the form of altered mental status. Yeah. So in a setting, in a scenario of multiple fractures, and the patient presenting to us with respiratory complaints or neurological complaints, and obviously there is one more important finding, and that is petechial rash. Although not giving the question, but usually that is an uh, you know associated presentation. So the moment you have this kind of presentation, like P and R, so the moment you find this PNR in a setting of multiple fracture, always think of the diagnosis of fat embolism. So multiple fractures, PNR, that is P for petechial rash and for neurological manifestations, and R for respiratory manifestations like dyspnea here. Yeah, so this is all going in favor of fat embolism. Now, what what actually is this importance of this term, multiple fractures? Now, what happens if there are multiple fractures? There is high possibility of the fat globules gaining entry into the circulation. Right? So the fat globules from the bone marrow, obviously this is from the bone marrow, and they can get entry into the circulation, and then they can travel as an embolus. So this is the classical picture of fat embolism. And if asked about like the most common fracture which is most susceptible for this kind of presentation, you should write fracture shaft. So shaft femur is one of the fractures which carries high chances of fat embolism, right? And therefore, whenever we are dealing with a case of fracture shaft femur, we always tell that don't manipulate the patient unnecessarily. Don't do unnecessary shifting because that will promote the chances of fat embolism, right? So this is a very important question, and it has been repeated over the years. So this is, I think, all of you must have done it right, because it's not like something new or a very complicated kind of question. The moment you have this kind of presentation, I think everyone can go and make it a diagnosis of fat embolism, right? So this was one question from complication of fractures. Now, the major segment was lower limb injuries. And here, one of the question was like a young adult patient, and there was an X-ray which was showing a fracture. So, young adult patient with a fracture. Now, what is the treatment? So, firstly, we have to and this is always advisable in cases of evaluating hip injuries, because sometimes we need to compare it from the other side, right? So therefore we always go for including the other uninjured side as well. So here we can classically see the fracture, something like this. Okay? Here we can classically see the fracture line. So this is fracture neck of femur. So I think everyone can see this is classical fracture neck of femur. The diagnosis is quite obvious. Now, what is the catch here? The catch is the age of the patient, because this determines what management we need to do. Clear? So fracture neck of femur in different age groups needs different management. Suppose if it is in children, although not related to the question, just related to the topic. So suppose if it is a case of children, we need to do internal fixation. Okay? So in children's, we need to do internal fixation. We can use Moyle spin or by Moore spin. Okay? So in children, we need to do internal fixation. Now, same is the concept with adults. And when we say adults, physiological age less than say 60 years. In such cases, again, we need to do internal fixation because we have to preserve the head of the femur and the neck. So again, we go for internal fixation. And here, what we do, we use multiple cannulated cancellous screws. Okay, so here we use multiple cannulated cancellous screws. So in this particular question, since the age group of the patient is young, so we will go for internal fixation. Now, there is one more age group which we need to discuss here, and that is usually the most important one in clinical practice as well, and that is elderly. Now, elderly are the one which are physiologically more than 60 years of age. Now, in elderly, one of the problem is that the bone is osteoporotic. So the likelihood of the implant which was used in adult being held at place is less. So the bone doesn't have that grip. It will not hold the implant as nicely as it will be holding in case of young adult. So one one factor is this. Second factor is more chances of non-union. Obviously, if the bone quality is not good, the chances of union are also not good. So, based on these 2 points, we presume that if we do any internal fixation, that might fail, and then we have to go for a revision surgery. So it's better, rather than taking the chances and unnecessarily putting the patient for a revision surgery, better we go and we do a hemi replacement arthroplasty. We do a hemi replacement arthroplasty. Now, what is this word actually? Hemi replacement. Hemi means half. So hemi means half here. Now see, the hip joint, it is composed of 2 parts. One is acetabulum. The another one is the head of femur. So there are 2 parts. And when we are operating on the fracture side, what we are doing, we are removing the head and we are also removing the neck. So we are removing this much part, only this much part. And therefore, we are removing the half portion of the hip joint. Acetabulum is untouched. So we are touching only the half portion, that is the head of femur. You can say head plus neck of femur. Right? So only this part is touched. The other half, that is acetabulum, is untouched. We don't do anything here. So therefore, we are using the word half. Only half is touched. Replacement. The bone is taken out and we put a prosthesis, a metallic prosthesis. It is an Austin Moore or Thompson's prosthesis. It can be Austin Moore's or Thompson's prosthesis. Arthro is joint and plasty means reconstruction. So from exam point of view, what you need to remember, in different age group, what is the approach for this particular fracture? In children, internal fixation. In adults, internal fixation. And in elderly, we will do hemi replacement arthroplasty. We can also use a modular technique, right? So bipolar technique as well. Okay, so these are the different options with us. And since in the question is about younger patient, so in younger patient we have to do internal fixation. We try to preserve the head of the femur, the neck of the femur. Clear? So this is extremely important, and over the years we have a question from this particular topic almost in every exam, whether it is FMG, NEET, PG, or even INICET. So depending on the exam, the toughness or the level of the toughness of the question might differ, but the topic remains the same, right? So this is very important here. So if we talk about hemi replacement, arthroplasty, this is only done in elderly patient, right? There is no role of external fixation here because external fixation is usually done for either open fractures anywhere or fracture of pelvis, usually to control bleeding. So it is done for fracture pelvis, or you can say open fractures anywhere of the limb. Then total hip replacement, when we use the word total, it means acetabulum is also reconstructed, and this is usually done for osteoarthritis, when both the articulating surfaces are damaged and we need to replace them by prosthesis. So that is total head of femur and also acetabulum. So that becomes total. If we are only replacing head of femur along with the neck, that is hemi replacement, right? So just the words. So again, this is very important. And this is how we have a different algorithm based on the age of the patient, right? So this is very important. Then there is one more thing, uh, and it's about like the capsule of the hip joint, right? So the capsule of the hip joint is something like this, and it runs anteriorly. It is something like this. So it means this kind of injury is lying within the is falling within the capsule of the joint. So this is intracapsular, right? Intracapsular neck of. Is that clear? Why we are calling it intracapsular? Because the fracture line is within the joint capsule of the hip. So this is intracapsular. Now moving forward to another question. Again, it's about a case of road traffic accident and a fracture was shown. Now, what is the fracture actually, which is shown in the X-ray? Now, it's pretty easy. Like you can see, this is head of femur, this is neck of femur, this is greater trochanter here, right? Lesser trochanter, right? So, and this is of course acetabulum here. So what we can see there is a fracture line which is running somewhat like this. So the fracture line is running through the greater trochanter to the lesser trochanter. So if we talk about the fracture line is running from greater trochanter to lesser trochanter. Yeah, to lesser trochanter. So it means it is running between the two trochanters, and therefore its nomenclature is intertrochanteric, because it is running between the two trochanters. So it is intertrochanteric or intertrochanter fracture. So the word is intertrochanteric fracture. Yeah. Now, what is important here? Look at the type of bone. The bone here is all metaphyseous, right? So this is actually metaphysis. So the bone all here is cancellous bone. Right? Cancellous, number one. Number two, cancellous bone has a good healing potential because it is highly vascular. You know that metaphysis is a highly vascular zone. Cancellous bone, they have a high osteogenic potential, good healing potential. So it means if there is any fracture, it will heal nicely. Yeah, this is one important thing here. So it will heal nicely, and therefore we see that majority of the cases they heal properly. So what we need to do here, if we talk about the treatment, we need to do open reduction and internal fixation by DHS. So we have to do a surgery that is known as dynamic hip screw. So this is dynamic hip, right? So there is a screw which is passed, and then there is a uh, barrel plate which is applied something like this, held with screws. Yeah, so that is DHS. So DHS done for intertrochanteric fracture. Now again, we can do one thing. We can just take the capsule of the hip joint. So we discussed that capsule of hip joint is something like this. Okay? So the capsule of hip joint is something like this. And now what we see here, the fracture line is outside the territory of the capsule, right? So what you call this? This is an extra capsular fracture. This is extra capsular fracture that is outside the territory of the capsule of hip joint. Now, what we can do? We can just write the two injuries which we have discussed in relation to capsule of the hip joint. So on one side, I'll write intracapsular fracture, which is actually the neck of femur fracture, right? So this is neck of femur fracture. And on the other side, I will write the extracapsular fracture. And extracapsular fracture, what we have discussed here is intertrochanteric fracture. Okay, so these are some additional terms for these two injuries which you should know. So obviously, if I write like relation with capsule, so intracapsular means it is inside the capsule, and this is outside the capsule of the hip joint. Now, why we are discussing this point? Because in fractures around the proximal femur, there is tendency of external rotation of the lower limb. So the lower limb might go, it has a tendency to go into external rotation. Now, what happens when the fracture line is within the capsule? The external rotation is not freely possible. So the limb will rotate a little bit, but because of the capsule, the free rotation will not occur, and the amount of external rotation will be around somewhere around 30-40 degree only. But in a case where the fracture is outside the territory of the capsule, the lower limb will rotate freely, and therefore the degree of rotation will be more than 45 degree, and it can be up to a point till the lateral border of the foot touches the couch. This is one thing, right? Then another thing is in relation to complications, or before that we can write outcomes. Now, because the intracapsular fracture neck of femur is through the area where the the union is very, problematic. At times it does not happen. So unions, it might not happen. But here union is good. Extracapsular variety or intertrochanteric variety is through the metaphyseal cancellous bone. So union is good. And therefore, if we talk in terms of complications, non-union is a problematic complication in intercapsular. But since union is good, so here we can find malunion. Means the fracture will unite, but it might unite in a wrong position, and at times we have coxa vera deformity. So these are the different differences which you should know about these two entities, and at times they are being asked as well. So both of the fractures are very important, and luckily we have a question from both the entities in the same exam. Now, knee injuries are again a very important segment, and here we are having a question from knee injuries, or say sports injury, and here a clinical test is being performed, and it was up to students to identify which test is being lying supine. Right? So patient is lying supine on the couch, hip is flexed, hip. So this is hip. Then knee is also flexed. This is of course knee. So knee is also flexed, and it is flexed somewhat to 90 degree. Yeah. So this angle is, say, somewhat 90 degree. Then the examiner has stabilized the foot. So examiner has stabilized the foot. Yeah. He is sitting on the foot, and therefore he has stabilized the foot. Now look at the position of the hands. position of the hand of examiner. Look at the thumbs. Thumbs are just above, on the anterior part of the tibia. So you can say around tibial condyles, and the fingers of both the hands, they are behind, they are posterior. Now what actual maneuver the examiner will be doing, he will be pulling the upper part of tibia anterior. Okay. So if we go into the examiner will pull the upper part of, yeah. So this is what the examiner is trying to do. Now normally what happens? Normally this is not possible, and we call it anterior translation of tibia. Anterior translation of tibia is not possible. Why it is not possible? Because of intact ACL. What is ACL? Anterior cruciate ligament. So if anterior cruciate ligament is okay, it is not easy for us to do anterior translation or anterior movement of the tibia, right? But in a case where there is ACL tear, we can easily pull the upper part of tibia anteriorly or in a forward direction. Yeah. So that is what is being tested here. The structure which is tested here is ACL, and this test is known as the anterior drawer test. Right. So this test is the anterior drawer or anterior drawer test. Now, sometimes when there is so much of injury, it is not possible to flex the knee to 90 degrees. So in such cases, what we do the same maneuver, but knee flexed to around 15 degree, which is easily possible. And then this modification is known by some another name, and that is Latchman. So this Latchman test was a question in NEET PG, and in FMG we have anterior draw test. So the mechanics or the basic concept behind the two tests remains the same. We are looking for anterior translation of tibia. If it is possible, it is an indicative, right? So this is both the test, anterior draw and Latchman. These are done for ACL, TL, right? So just remember that. Then the two questions, they were actually trauma based but related to neurology, or you can also count them in complications. So that is again overlapping kind of thing. So here a fracture is shown on the X-ray, and then it was asked that which nerve can be injured here. Now I think this is one question which is repeated almost every year and in almost every exam. So this is almost repeated every year. So here we can see this is humerus, okay? And we can see somewhat spiral fracture through the mid shaft. So there is a spiral fracture through the mid shaft of humerus. Now there is a nerve which goes like this, and then it passes behind the shaft of humerus to come onto the lateral side. So this nerve is, I think most of you must be knowing, this is the radial nerve, and it passes through a groove over the posterior aspect of the shaft of humerus. That groove is actually known as spiral groove, but since the content is radial now, so it is also known as radial groove. So what happens? There are high chances of injury to this nerve as it passes behind the shaft of humerus through the spiral groove. So classically, this will result in radial nerve. Okay. So the fracture which is shown here is fracture shaft humerus, and it puts the radial nerve at risk of being injured. And there are some other questions which are also asked from this topic, like what will be the deformity. There are very specific set of questions which are related to this topic. So deformity is, I think all of you must be knowing that this is wrist drop. The person is not able to dorsiflex the wrist, right? So inability to dorsiflex wrist. Now, what we need to do? We need to give a splint, and that is walk-up splint. In older times, we used to give static splint, but nowadays the concept is give a dynamic splint so that at least the flexors are get into activity. So this is dynamic cock-up splint. So this is radial nerve injury for this fracture. Then there was one more question about nerve injury related to a fracture, and here different labeling of the bone was done, and it was asked like fracture of which part will lead to loss of dorsiflexion. What is the movement, like what muscles are responsible for doing dorsiflexion of the foot? So these are actually the dorsiflexors, which are supplied by the deep peroneal nerve. Okay? But deep peroneal nerve is usually not injured in fractures. Its parent nerve, which is the common peroneal nerve, can get injured as it winds around the neck of fibula. So what we need to do? We have to locate the neck of fibula. So this area is the neck of fibula here. And this is the way in which the common peroneal nerve comes, and it divides into its two branches. So one branch is of course deep peroneal nerve, and the another branch is the superficial peroneal. Okay. So what is happening here? If there is a fracture around the neck of fibula, there is possibility of injury to common peroneal nerve. As a result of this, there will be injury to deep peroneal nerve. The dorsal flexors will be paralyzed. The patient will not be able to do the dorsiflexion of the foot, and this has foot. So somewhat similar to wrist drop, which we have just discussed. Okay, so the landmark number is 6, and this 6 is actually the neck of, yeah. So nerve, which can result in foot drop. Okay, so please remember this. And the superficial peroneal nerve, it supplies the inverters of the foot, especially the peroneal. Okay, so this is